So now, without further delay, I will transition to our second keynote speaker. Dr. Ken Carswell will present Scalable Digital Psychological Interventions, a Global Perspective. Ken Carswell has a background in clinical psychology as a technical officer with the World Health Organization Department of Mental Health and Substance Abuse in Geneva. He is the departmental focal point for innovation in digital mental health and scalable psychological interventions. He's had a central role in developing numerous projects and programs that have reached hundreds and if not thousands of people and have the potential to scale to massive numbers of people following rigorous randomized control trials. He's been centrally involved in development of a number of WHO psychological interventions, including self-help interventions that use technology like Self-Help Plus and Step by Step and STARS. Increasingly, he's been involved in supporting the implementation of these packages globally. And he also works on the development of other digital tools, such as smartphone app versions of the World Health Organization's MHGAP intervention guide, which supports non-specialist providers to manage priority mental health conditions. So really excited to share his keynote. Just give me 1 second. All right. I'm going to try to. Just give me a second. There we go.
Hello, everybody, and good afternoon. And thank you for the opportunity to talk at this important event on scalable digital interventions to address mental health during the COVID-19 pandemic. It's my great pleasure and my honor to have been invited to deliver this keynote address. And I hope that the talk will provide you with an introduction into WHO's work in this area, as well as some potential tools and options that you have for delivering support and things that may help you with this during the COVID-19 pandemic and beyond. So my name is Ken Carswell. I'm a clinical psychologist by training, and I'm a technical officer at WHO in the Department of Mental Health and Substance Use. I'm a focal point there for digital innovation in mental health, and also for the area of scalable psychological interventions. So today, really, I wanted to give you an introduction to some of our work. And really, the work has been going on for a number of years, and is a result of fantastic collaborations with a number of different partners who really are too numerous to mention, and some of whom will be speaking here today. So I imagine you might hear a little bit from other talkers, other speakers, about WHO interventions, and hopefully maybe some of this might be inspiring and give some ideas on how these different tools and approaches can be used in the mental health response. Okay. Okay, so just to give you a brief outline of what we're going to cover today. First of all, I'm going to give you an introduction to WHO's work in this area, and then we're going to talk a little bit about adapting in-person WHO interventions and thereby other interventions for digital or remote delivery. I'm then going to talk a bit about some digital self-help interventions and some options there, and close with a bit of a summary and a few considerations and thoughts. Okay, so first of all, why do we need digital psychological interventions, or why do we need to innovate when it comes to psychological interventions? As many of you probably already know, there are hundreds of millions of people worldwide affected by prolonged, disabling emotional distress and mental disorders. And these may be caused by adversity, which can take many forms and be caused by many things. It could be poverty, conflict, humanitarian situations, post-conflict environments, and of course, what we're experiencing now with COVID-19 and a global pandemic. We know that from extensive research over many, many years, we know that psychological interventions can be effectively delivered by non-specialists. So, there was a time when we would think that maybe psychologists would be the ones who have to deliver psychological interventions. We now know very, very well that that's not the case, and there's extensive research, randomized controlled trials, and similar sorts of work in a number of different countries, high-income countries, low-middle-income countries, and a number of different settings, which very clearly demonstrate they can be effectively delivered by non-specialists when there's supervision and support offered to the helpers delivering the support. Now, I would say that globally and everywhere, there is a need for innovative, low-cost solutions to mental health in all countries. This is because even in high-income countries and countries with a number of psychologists, there just aren't really enough specialists to deliver these sorts of interventions and this type of support. So we do need innovative approaches, and psychological interventions are a promising approach. Now, there is a number of innovative and well-evidenced interventions that are available. So, for example, some of you may have heard of something called the friendship bench. But unfortunately, sometimes these aren't always so easily available. So there does really remain a need for more highly innovative and low-cost approaches. And this may be the case when it comes to digital interventions, because we see those as an approach where you may be able to reduce cost and increase scale through the delivery approaches and mechanisms. Now, I think we can all agree that COVID-19 has greatly increased the need and the demand for mental health support, and particularly digitally delivered. I mean, it's an interesting reflection to sort of see how pretty much, very, very quickly the world moved from delivering services in person to then very quickly having to adapt to deliver support remotely, either through the telephone, digitally, online, etc. I mean, one thing that one of my own sort of reflections here is that often when we think about digital delivery of interventions, we often think about apps, about video conferencing. But obviously there's other means such as the telephone, WhatsApp, messaging, other forms of technology which may be more widely used. So I suppose when thinking about digital interventions, sort of very much thinking about a multiple range of different approaches, and I think during the last year or so there have been many examples of different and innovative ways to provide support to people, depending on their context and depending on their access to technology. Okay, so just to say a little bit about WHO's current objectives and work in this area. So for a number of years, we've been working on psychological interventions, and we've been publishing a range of different, what we call scalable psychological interventions, with the aim of increasing access to effective care. Now, the approach that we've been taking is that we will develop what we call a generic version. So this is a version of the manual or of the intervention. And we then look to then test it in randomized controlled trials, minimally in 2 countries or with 2 different populations. And this is done very much in partnership, where we have WHO providing technical support. We have a strong implementing partner and a strong research partner, which allows us to do very highly effective and well delivered randomized controlled trials. And we've done this now for a number of the different interventions that we will talk about today. Okay, and how we publish these interventions is we use WHO Press, which means that we can put the manuals and the resources online and in the public domain, which we would suggest would then lead to greater take-up and dissemination, because they're published generally under Creative Commons, which means they're free to use, free for people to access and to adapt. Okay, but it's important to say as well, it's not just about putting the manuals out there. We're also looking to develop guidance and mentoring and support to enable implementation of scale. of both WHO and non-WHO interventions. Now, in terms of the guidance we're thinking about here, we're thinking about things like adaptation, how you might deliver such interventions in a range of services, what resources might be needed, and just support for any implementing organization, any implementing agency to deliver this type of support. Okay. So when we're talking about scalable MHPSS, mental health and psychosocial support interventions, we can think about it on a bit of a continuum. We start down here, the lower resource intensity and probably the lowest form of resource intensive intervention would be unguided self-help. So this might be a self-help book or a self-help app online that's delivered with no support. Next up, we have guided self-help, which may be a book or online delivered with some form of minimal support from a trained helper. So for example, a 10-minute motivational call once a week or so. We then move up to group and telephone delivered interventions. So this might, for example, be interventions that are delivered over the telephone or in groups, because still they take fewer resources. We then move up to maybe things like multi-session individual face-to-face interventions. And as we can see here, the resource intensity is getting much higher because we're talking about one person seeing one person. And then finally, we end with specialist delivered interventions, which are probably the highest resource intensity. And I'd say that most psychological interventions can be mapped somewhere along this continuum. Okay, so let's think about and look at the types of interventions that WHO has already released. We've released so far 4 different interventions. We have PM+, Thinking Healthy, Group IPT, and it's not quite on this slide, but the 4th one that we've just recently released is Group Problem Management Plus, so the group version of PM+. And these are all available on the WHO website, and you can access them by typing into a search engine the name and WHO, and you'll be able to find the page. So these interventions are all delivered by non-specialists in different health and other settings. All of these are all in-person or face-to-face interventions, but we are also working on self-help delivery as well, which I'll talk about later. We were aiming to develop a range of transdiagnostic evidence-based interventions and also working across the lifespan. So some of the intervention I'm not mentioning here because they're not yet ready for release are interventions aimed at adolescents. So we have an intervention called EASE, Early Adolescence Skills for Emotions, which is for younger adolescents. And we're also working on a chatbot delivered intervention for older adolescents and youth. But both of these interventions are still in the testing phase. Now we think about different methods of delivery, such as individual, group, and technology supported. And as I mentioned, we've released 4 manuals so far. So we have a guideline at WHO to support this work. This is based on the MHCAP recommendations from 2015 for depression. So as an example, here you can see we talk about health providers providing different formats, different types of treatments, different formats. It can be individual, group, face-to-face, self-help. And the bit highlighted here really is that self-help psychological treatment may involve information technology, supported self-help materials, and paper-based self-help books. So we're covering all of it there. Now this recommendation goes on to both mention the importance of both guided and also unguided self-help, which I'll talk about a little bit more in a moment. Okay, so the first thing I want to just briefly cover and discuss is in-person interventions adapted for remote delivery. So obviously with COVID-19, services and the providers moved quite quickly to delivering support remotely. This is an interesting paper I found. I remember reading it at the time because it outlines some of the aspects of work in this area. It firstly outlines that psychotherapy delivered by video conferencing does show promising results, that therapist-supported internet interventions have a good evidence base. It also highlights that probably in a matter of months, things changed at a much bigger speed than had happened over many years. and outlines that maybe perhaps part of the reason for that was that such interventions weren't integrated into routine practice. And the authors here argue for such interventions to be integrated. But one of my main takeaways from this paper is that psychotherapy, i.e. psychological interventions, can be delivered remotely. They can be delivered over Skype, over video conferencing, and over other methods as well. So I think that's quite an important takeaway from this. We have started seeing work on some of our own interventions in this area. So, for example, we know that there are clinical trials underway for remotely delivered PM+, and there's a couple of examples there on the right hand of the screen. And we also, our colleagues at the Red Cross Psychosocial Centre had a project where they were supporting New School University to deliver remote PM+ training. Now that there is another, this is an ongoing project, but some of the initial lessons that were learned was that PM+ adapted for training remotely was practical, it was feasible. However, there was extensive work needed to adapt the training for the online environment and to ensure things like collaborative group work, that people remained engaged, that they remained participatory. But I think my takeaway from this work so far is that it is feasible to do remote training with the necessary adaptations, and again with good ongoing support and supervision. So again, this is, I suppose, another message where we're sort of seeing that some of the things that are already out there can be delivered remotely to support in different contexts and different situations. So just to summarize on this part, really we see that evidence does suggest that psychological interventions can be delivered remotely with the appropriate adaptation and training. So this applies to things like PM+, it applies to other evidence-based manuals. It suggests that these things can be adapted. There's work going on around the adaptation of group-based interventions. Now again, as always, you know, this work is in part dependent on the context. So for example, in some contexts, video conferencing might be appropriate and feasible. In other contexts, it might not be. You might be thinking about telephone or WhatsApp or other delivery methods. But with some careful assessment and some careful formative work to really understand the population, this can be done. And I think that's another point actually that's quite important to make, is just the importance of this piece of work around adaptation. So very often in WHO and in our work on psychological interventions, we talk about the importance of cultural adaptation. And I suppose when we talk about digital interventions, we have to think very carefully about access and access and also usability of the interventions. So part of that initial adaptation work might look to see, well, what types of technology are accessible to different groups? Are there any constraints, for example, data access? Are there other constraints, for example, access to a mobile phone signal or anything like this? And it's important to do that to understand the needs of the populations and how they might best be accessed. And it might be a case that there might have to be several different routes of access that are provided to support digital interventions. Now, one thing about in-person interventions that are adapted for remote delivery is that all of the factors required for successful in-person delivery, such as trust, building a good rapport, confidentiality, supervision, all of these are necessary also for remote delivery. However, there are additional factors to consider as well. And not only additional factors, but I suppose when we're delivering over remotely, then we're thinking about, you know, we might be having to either change the way that we deliver things. So for example, if it's over the telephone, somebody can't see facial expressions, so there might have to be more intonation in the voice or more conveying of emotion through the voice or conveying of trust and openness. And conversely, it might mean that the helper needs to pick up on different types of cues. So for example, you know, non-verbal communications may not be there. So we might need to think about, listening in more closely for some of the verbal and the other cues that we might have that we would normally be able to see depending on the delivery approach. And obviously there's then other factors such as sort of making sure that the person is in a suitable, secure environment, that it's confidential, that they can't be heard, and things like this. So there are things to be considered and thought about when moving on to a sort of remote delivery model. Now, to support this work, there has been extensive resources developed, I suppose, over the last year, and you can find many of these on mhpss.net. They've collated a number of resources for response to COVID-19. And if you go there, there's also a section there on remote delivery of support. And then at WHO, our EQUIP project, so we have a project called Ensuring Quality and Psychological Support. EQUIP developed resources to support remote delivery of psychological interventions. And there's the website, and here you can see the page. Now, these were developed. EQUIP is a project looking at how we increase quality through competency-based training and assessment. And EQUIP was a project that was looking to develop and is still developing competency assessment tools and support for the quality delivery of services. However, partway during the project, COVID-19 happened. And so the team in EQUIP developed these resources in part for their own project. And then we decided to release them more broadly because they provide a very, very good, simple, easy to understand overview of some of the key aspects that you might need to consider when delivering remote support. So now we're going to talk a little bit about self-help guided and unguided support. So as I've mentioned so far, there's extensive evidence to support self-help, both in guided and unguided forms. Self-help is a book, app, any other type of material that's aimed to reduce distress or improve well-being. And guided self-help uses self-help resources with a brief support and motivation from a trained helper, whilst unguided is the use of the material without that form of support. Now, we know that effect sizes for guided self-help from extensive research over many years tend to be larger and in some cases equivalent to therapist-delivered support. It's also important to mention that when we're talking about the research here, we're talking about people across the spectrum of severity and distress. For example, we're not just thinking with self-help about it being suitable for people with mild levels of distress or who haven't been diagnosed with a mental disorder. Instead, we see it being effective for people with more severe forms of depression as well. Obviously delivered with support and with the necessary risk management. Okay, but it's important to just mention that it can be supported and helpful across a range of conditions. So if we think about availability of self-help materials, what do we know about that? Well, there are many commercial and non-commercial self-help resources available, but I think this quote here really sums things up. That there is currently somewhere between 10,000 and 20,000 mental health apps available. But it's estimated that only 3 or 4% are actually evidence-based. Now, even if those figures are a little wrong and it's actually 10% of the apps, we're still talking about an extensive number of applications that aren't evidence-based. So I think that's one of the most important things is when considering self-help and digital self-help to really consider the whether it's been adapted, whether it's evidence-based, whether it's suitable for the types of populations you're thinking about. And there are some very good examples out there of different interventions that are evidence-based, but it's also a bit of a signal that many of them are not. Now, unfortunately, many of the resources that are out there are only in English and they haven't been designed for different cultural contexts or adapted for different cultural contexts. So this is one of the reasons why we at WHO started working on self-help materials. Okay, so as I've already said, it's important to consider the evidence base and the suitability for the context. And we've been working to develop these different evidence-based approaches to try and make them suitable for many contexts after adaptation. Okay, so the first one that I want to talk about is step by step. Now, step by step is an intervention that's been developed over 6 years by WHO in close collaboration with a number of partners, including the Ministry of Public Health in Lebanon, Free University Berlin, the University of Zurich, and a number of others. It's a transdiagnostic intervention, so we're looking at it being supportive of people experiencing stress, depression, and anxiety. And it includes behavioural activation and elements of problem solving, stress management, and strengthening social support. The approach that's taken with it is through an illustrated story of a person who has learned ways of managing their distress. And I'll show you a little bit of the intervention now as we go. We've just completed trials in Lebanon, where we're now preparing the papers for publication, and the results were promising. So based on this, we'll be looking to release step by step later this year. We also have 3 further RCTs underway with Syrian refugees under the Strengths Project, which you might hear about later on today, and other research underway with other populations. So what is step by step? Well, it's a brief intervention, 5 sessions, which are completed over 3 to 8 weeks, depending on how quickly someone uses it. It's minimally guided, so the version of step by step that we used in Lebanon, users receive 15 to 20 minutes a week in the form of a telephone call from someone called an e-helper, which is a trained and supervised non-specialist helper. Now, there is also the option of delivering it unguided, or with guidance on demand. So it's quite a flexible intervention in how it can be delivered. There are a range of different interactive activities, so people get to practice the activities that they're learning through the story. And we've introduced a form of tailoring into it, so to make it a bit more engaging for people, where users can actually choose a character to follow the story. So these are the characters from the Lebanon intervention. And we've got 2 women characters, 2 male characters who have been adapted and designed to sort of respond to the sort of broad cultural aspects that we find in Lebanon. Now, let me just close this. There you go. So this is an example of the step-by-step intervention. So here it's explaining that there are 5 sessions, and that each session contains 2 or 3 small parts. Now in this one here, you can see the characters learning about the importance of practicing the sessions and how that might help them and support them. In terms of the overall intervention, we have the sessions, which we said 5 sessions, along with a baseline, a set of baseline questionnaires, an introduction to the whole program, and also a post-test. So users also complete or can complete questionnaires each week, which can also help the helpers to understand what their needs might be. Now, in the so-called toolbox, so these are the activities, we have a range of different activities that people can complete. Some of them are based on behavioural activation and around enjoyable activities, difficult activities and managing these. The self-care activities and relaxation stress management, such as grounding exercises, slow breathing exercises. And then within the app and the website, there's a home button. You can access the activities, you can access these different aspects. So here's the home screen. So this is how it's laid out. At the top there, you can see the bit of the session that you click on. And at the bottom, you have your toolbox. And at the bar right at the bottom, we have access to the helper, a mood monitor, and aspects like this. And here's just an example of one of the types of activities that you might be able to do. So, for example, you can write down what your personal strengths are, or the things that maybe bring you some joy or support. And then we have another activity, which is a mood tracker. And here you can input your daily mood, and it tracks your weekly mood. And so it can sort of show you how your moods are changing and also how they might be related to some of the activities that you're doing. Just to briefly show you the e-helper model. So as we said, there's 15 minutes of support calls or messaging, and e-helpers both can provide technical support, so problems with using the app or the website, but also emotional and motivational support. So for example, this might be clarifying content, providing motivation, active listening, and also importantly, managing distress and high-risk situations. So the e-helpers have been trained in protocols to support people who are at risk of harm. So what are the opportunities for implementation? Well, the generic English version will be released under Creative Commons in 2021, and this can then be adapted for other cultures and contexts and languages. It can be that the content itself could be put on different delivery platforms. However, at WHO, we're now just starting a project to develop an open source platform for step-by-step, and that's due to be completed in late 2021. And we also have an implementation project with our colleagues in Lebanon to really help us to implement step-by-step at scale, and to really then understand how we run a digital mental health intervention at scale across our whole country. And from that, we'll be able to develop lessons learned and other advice and support for implementers. Another intervention I want to mention here, because we're looking to release it again in the coming months, is Self-Help Plus. Now, this is a transdiagnostic intervention for adults. It's based on stress management, particularly acceptance and commitment therapy. And it's delivered as a large group intervention for 10 to 30 people. There's a pre-recorded audio course, which provides all the sort of technical information on managing stress. It takes you through grounding and relaxation exercises to do with clarifying your values. And a lot of the content is provided by the audio, with facilitators there to support the group work and discussions. Now, it's been developed over the last 5 years, and we've improved it iteratively with each project. We completed one cluster randomized controlled trial with South Sudanese refugee women, and that was published in 2020, and that had very positive results. And we've recently completed 2 more randomized controlled trials in 2020, where we used Self-Help Plus as a prevention intervention, where we had a primary outcome of incidence of mental disorders at 6 months. And this was with refugee and asylum-seeking populations. Those papers are being currently written up and published, but the results were again promising. So based on that, we're looking at releasing, we are currently working on releasing Self-Help Plus for it to then be used widely as per our other interventions. Now, once released, it's then available for adaptation for different cultures and contexts. Now the evidence for Self-Help Plus and the way that we've developed it and tested it has been in a group face-to-face setting. But I've been curious for a while now about the different creative adaptations that could be made to it. So, for example, is there a way for Self-Help Plus to be made into podcasts for people to use in small groups? Could it be used in some form of weekly webinar or live stream? Or could there be a large group-based Zoom call to run a group? These will all be very interesting adaptations for implementers to consider and explore, with obviously the suitable adaptations once it's released. Now, related to Self-Help Plus is what we call Doing What Matters in Times of Stress, also known as the Self-Help Plus book. This is already available on the WHO website. It's an illustrated self-help book that includes all the content from the Self-Help Plus course and very brief audio exercises to support practice. It's again aimed at adults who are experiencing impairing levels of psychological distress. Now, the book's on the website and it can be delivered guided or unguided. We have a guidance protocol, which I'll talk about in a moment. Again, this is obviously based on acceptance and commitment therapy and as part of Self-Help Plus. Now, this book hasn't been tested in trials, but we field tested it with 500 people from Syria, and it suggested it was widely liked and used. Here's just a few images from the book, which you can download if you're interested. And here we have the narrators who are explaining their role in introducing stress management techniques. And again, talking here about the concept of unhooking and helping people to engage in life, and how if we unhook from our difficult thoughts and feelings, we may be able to engage more in the things of the world around us. And here's the actual instructions in terms of how we unhook. So the two steps in unhooking are you notice and then you name. So you notice, here's a tightness in my chest, here's a painful memory, and then you name it. Here's a painful memory. Okay, so that's a little introduction to doing what matters. Now, in terms of opportunities for implementation, it can be delivered using a similar model to step by step. And we've actually developed a draft guided self-help protocol for doing what matters, which you can contact this email address or myself, because the protocol outlines, I think it's a 3-session protocol, basically to support and motivate people in using the book. And we've developed that, and it's available there for use. However, under an EC-funded project called Respond, Doing What Matters is being adapted into an app and then tested as part of a remotely delivered stepped care model as part of COVID-19. So in step 1, DWM will be provided, and step 2, remotely delivered PM Plus will be delivered. So that project's just started this year. And results will take some time to come out, but we're hoping that as a result of this project, we'll be learning quite a lot about how DWM and remotely delivered stepped care can be feasibly delivered. Okay, so that gives you a bit of an overview and a bit of a tour of some of our working in WHO in this area. Hopefully it's highlighted that there are a range of different things that are available. Some obviously we're still working on, and we're still working on releasing those, and we're very excited about that. And there's still some opportunities there that are available. There are opportunities to use some of the materials that are already available now. So just in closing, I'd just like to summarize that. I mean, really, we see that digital interventions are supported by extensive evidence. That existing interventions can likely be adapted for delivery. Now, as I've mentioned, it's important to consider the sorts of technologies that people are using. It's important to think about the ways they're going to access them, about privacy and security. There's a lot to think about. However, it can be done. I think that's quite an important message, I think, to take away. So indeed, digital delivery takes some time, thought, and careful consideration. It's important to consider the accessibility and the technological context. And something I haven't touched on so much is that it's important to embed such interventions within a service model that provides support on multiple levels and allows for some form of integration. So for example, this might be stepped care models. It might be referral for more intense support. Or for example, if an intervention is being delivered digitally, obviously when it comes to matters related to risk, it might not be so easy to respond to risk. To suicidal ideation or to concerns about somebody. So it's also important to build up around this, to deliver it and embed it within a service that allows for that type of support. So for example, just a little story in terms of some of our work in Lebanon. The team there developed a great system for responding to anybody who was at risk of harm. Or was at risk of imminent risk of suicide, where the e-helper would assess the person. They would come to a decision. If the person was at imminent risk of harm, a supervisor would be alerted and have a further telephone call with the person. And then they were then directed or taken by taxi to a local hospital that was trained in MHGAP care. So I suppose even at quite a big level at scale, it is possible with some thinking to develop approaches around digital interventions that can mean that they can be delivered and provided with access to other services and means of support, which I'd say is a very important aspect. And also important to remember that not everybody will have access to digital intervention. So also thinking creatively about how can we deliver support to as many people as possible through a range of different means and methodologies. Okay, so thank you for your time. I hope you enjoyed the talk. This is obviously where we would now go into questions, I'm sorry that we don't have that, but I'm looking forward to joining the panel shortly after this talk, and hopefully I will hear some of your questions and reflections then. So thank you for your time, and I hope it's been of some use and interest to you. Okay, thank you very much.
Welcome back. So thank you to Dr. Carswell for his excellent talk. I think one of the things that's really striking about the work that WHO has been doing right along and for at least the past 6 years has really been focused around rigorous evaluations of scalable psychological interventions. So interventions that are delivered, again, on a continuum from a low to a high intensity model. And really, a lot of the interventions that were discussed in Dr. Carswell's talk were really lower intensity interventions delivered either by lay health workers, delivered online. And the similarity, the things that were mentioned both in Professor Kuiper's talk and Carswell's talk was about distilling the evidence-based practices in a bite-sized way for people to metabolize without having a high-level specialist service provider available to deliver the care. And I think that's really an important point. I also think it's important that they mentioned cultural adaptation and cultural adaptation of the intervention to make sure that it's suitable not only for the group that you're trying to reach, but also suitable for the context in which you're trying to deliver it. And I think that speaks directly to implementation science, which is going to be covered later this afternoon. And really making sure that the intervention, no matter what it is, has trial evidence and it's evidence-based to meet the needs of the population that we're trying to work with. Another important take-home message was that models can be remotely evaluated and tested. Some of the programs that Dr. Carswell were mentioning were actually developed for in-person group-based treatment. But with COVID, there was a pivot to providing those interventions on an online platform. And so the trial evidence for that will be really interesting, and it's exciting to see that the trial evidence for all of these interventions are going to be released, and because they're positive, that these intervention programs will be released as a global public good, which is extremely exciting. The step-by-step program that was mentioned in that talk, we're going to revisit that in the afternoon because our team here in China has been working on that for several years, both for a cultural adaptation for both Chinese populations, also for Filipino overseas workers. So it'll be exciting to share our findings and also just lessons learned from the adaptation process and also from the trial evidence that we have amassed. So with that, I want to thank you all for attending our morning keynote sessions. Although our speakers are not here yet with us in person, at 2:30, they'll be here for a moderated discussion where you'll be invited to ask questions.